Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology Podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
We are back with Dr. Tina Bhutani, CEO of Synergy Dermatology in San Francisco, an associate clinical professor at UCSF, and previous co-director of the UCSF Psoriasis Center. Of course, our group knows Dr. Bhutani really, really well. Happy to have you back again.
Thank
We're
you.
so excited.
So excited to be here.
Yeah. And then one of the things that we've talked about over time is, of course, we always talk about the therapies that we do and the innovations, but there is this large overlying just health equity piece of, okay, so you have all these medications, you have all these advancements, but who has access to it? Who's included in the clinical trials to come up with these innovations? So there is so much underrepresentation in dermatology. And then one of the really, really interesting studies that you presented last year, actually at SF Derm in Half Moon Bay, was J&J's Visible trial. And I know since then you've also actually talked to me about the Spectrum trial. So I think J&J is really interesting in this regard as a company. And I really like, and that's one of the things they always say is they spend more on R&D and this kind
They really invest in the research.
They invest a lot in the research and looking at these like clinical gaps and trying to kind of figure these things out versus like putting their money into more marketing or things like that, which is really great. I mean, we love seeing trials like this, but I'll hand it over to, if you want to just kind of go over, should we start with the Visible trial? Would that be, if you want to just give us an overview of what that was?
Yeah. So to your point, I think, I think we're in this era where we think we have psoriasis all figured out, right? We have numerous approved, biologic agents. We have topicals, we have phototherapy, we have all these things. And I hear about it all the time. They're like, oh, you're lucky you work in psoriasis. We've got it all figured out. But the thing is we don't. And there's still so many unanswered questions. And I think what both the Visible and the Spectrum trial really got into was looking at these populations that haven't been studied before or where we don't have a lot of data. So specifically for Visible, it was looking at patients with skin of color, which we know is a population that's underrepresented in traditional clinical trials. When we look back at all of the approvals of all of our drugs, if you look at the demographic tables, right, they're largely Caucasian when it comes to the types of patients that are being enrolled in the studies. And what we know is that in skin of color, first of all, psoriasis can look a little bit different, right? So just you don't see as much of the erythema or the redness, when it comes to presentation. So it doesn't look like that typical textbook image of psoriasis. Right? So these patients oftentimes go misdiagnosed, undiagnosed. And so when they present to your clinic, they actually present at a later stage for the most part. So they're presenting with more severe disease because they've had a longer journey than our Caucasian patients getting to the dermatologist. The other thing, and there's actually studies out of UPenn that show this, is that doctors are actually less likely to offer systemic treatments or more aggressive therapy to patients with skin of color. So there's kind of this unconscious bias or something else going on, but patients are less likely to be prescribed these more aggressive therapies, which is terrible.
Yeah.
And so again, this is where Visible comes in. It was a study dedicated to just patients with skin of color. So that was a criteria for enrollment. The patients had to self-identify as non-white. That's how they were allowed to get into the trial. So we weren't looking at, what is your Fitzpatrick skin type, but you could only have a Fitzpatrick skin type 4 to enter the study. You could have any Fitzpatrick skin type, but you had to identify as non-white. And then again, they had to, obviously have psoriasis and be candidates for systemic therapy. There was 2 parts to the study. There was the first part, which looked at the traditional kind of generalized psoriasis in patients with skin of color. And then there was a second study, which looked at predominantly scalp psoriasis.
Yeah. No, that's so interesting when you presented this data last year too. And actually, maybe you did say that last year, and maybe I missed it. I did not realize the fact that systemics are not offered. Like, I wonder why. Like, that's crazy, because you can almost understand a little bit about the diagnostics because there are gaps, and even in our medical education, our books, the photos you see, so you could understand the gaps there. But once you have the established diagnosis and you know how much of the body surface area is covered, like, that's crazy to think that you're not going to follow the same algorithm.
They're not going to have the same algorithm.
This is what you would use. And and all of that.
Right.
So it's so important to kind of bring that all to light. So actually it's interesting was there a part, I know you mentioned last year where you were talking about like a specific tool that then that was used actually for the checking what the Fitzpatrick
skin
and all
types.
that.
Yeah. So again, all these patients had had psoriasis that were going to be treated with Tremfya in the clinical study. But what they also wanted to do was be very objective with the measurements of skin color and not just have our subjective interpretation of what this patient's skin color is, because again, that comes with a lot of biases associated with it. And so they used this device that's called a colorimeter, and they basically took the inside of a patient's arm and you put the little device on it and it spits out these numbers, and then you kind of have a table and it's able to equate those numbers into the different Fitzpatrick skin types. So like 1 through 6, basically. So it's a very objective way of measuring it. So you didn't have to, the doctor didn't have to think about, what is the skin type? How do they react in the sun? We weren't asking all of those questions because there's a lot of, again, unconscious bias that goes into that measurement.
Totally. Yep. And I loved hearing that. And actually, where can we get one of those? Because we do so much, let's say, even with phototherapy or cosmetic patients, we're kind of guesstimating sometimes.
Yeah, it's a really good question. I don't know the answer to that. I don't know. We'll have to ask J&J.
We have to call J&J. Like, where do you get this device?
I think we did get them as part of the clinical trial, and I think I was told that they are quite pricey.
Okay,
and so
do you
maybe
still
that's
have
the
it?
reason.
Can I stop by your office and take it? I guess these are
it, but
it's true. But I can imagine, we even used to see it at the psoriasis center back in the day on rounds with Gekkerman patients.
Yes,
patients that would burn at certain dosages and the dosimetry did not always correlate with Fitzpatrick's skin type.
Exactly.
So there was so much just kind of almost guesstimating, or like this, and then you would have patients with higher Fitzpatrick type that would burn at lower levels.
Exactly. Yeah. So your tolerance to sunlight or UV light does not always equate with skin color. So, oftentimes, like I said, in Gekkerman, I specifically remember we had, Black patients, for example, who couldn't take a lot of light, although the perception is that you should be able to take a lot of UV light. You have a lot of melanin, but that is, it's not always the case.
So I was found that was so interesting. And it just kind of points to what we talk about, we just don't know. These are gaps.
Yes.
We really don't quite have it figured out.
Totally.
Even with our therapeutics and all these different things.
Yeah.
Before we go to the Spectrum trial, anything I missed with the Visible trial?
So with the Visible trial, I think again, Tremfya worked great in these patients, and it was pretty similar to what we had seen in the pivotal trials.
The results,
so the results were as expected. We've used Tremfya in Skin of Color. We know it's a great drug. It works really well. And so what I always like to say is, I don't think that's why we did the study. I don't think the study was done because we expected.
We know Tremfya is going to work.
Yeah, we didn't expect it to work a lot differently in this population, but I think it was a proof of concept that we can do better when it comes to recruitment in clinical trials. We are able to recruit patients with skin of color. And in fact, this study recruited much quicker than anticipated, which never happens in clinical trials. It always takes longer to recruit. And in this study, they actually closed recruitment much earlier than they had expected it to. So again, just getting to the point that we can do better when it comes to representation in clinical trials. We just have to make the extra effort. They opened up new clinical trial sites. They brought in new investigators, people who are living in areas where they were seeing more patients of skin of color. They weren't using the same old clinical trial sites they always use for every study. They really went out there. They tried to market to the patients themselves and really try to bring people into the study. So they did a really good job as far as design of the clinical trial and execution.
Yeah, and it is really interesting to show that it can be done differently, because sometimes it's hard to say, why do this trial? Because we know Tremfya is going to work, but it is, and like you say, it's the right thing to do to be inclusive in clinical trials, but also economically, just having the points of, hey, you can recruit faster, you can fill your clinical trials faster. I mean, these are the initiatives that make sense to everyone as well. So for them to prove these points in a real life ways just moves everybody just moves the needle.
Totally.
Health equity. And we should be doing it just to do it, but also there are these extra benefits.
Yeah, absolutely.
Of kind of doing it as well and then learning more. And then was Spectrum kind of a similar setup, or how did that go?
Spectrum was a little bit different. So it wasn't focused on skin of color, but it was looking at another kind of underrepresented population in clinical trials, which are patients with low body surface area. So they had basically, the patients in the trial had anywhere from 3 to 12% body surface area. So lower than what we're used to seeing,
Yeah.
which is usually over 10% body surface area in these studies. And they had one special site of involvement. So areas like the scalp, the face, the genital area, palms and soles, things that are high impact areas for patients. So in order to enter into the trial, they had to have one of those sites of involvement. And again, I think these are patients where they come in and when you look at their total body surface area, for example, they might only have like 3%, maybe they have a little bit on the scalp, a little bit in the genital area. And we think, oh, well, 3%, that doesn't buy them a biologic, right? We're like, we're just looking at their skin. We're not actually thinking about the impact that those areas are having on the patient. And when you look at the impact, those areas, even though it's a small body surface area, they have a much higher impact on quality of life compared to just like elbows and knees or areas that you can cover up with clothing or things like that. Like these are areas where patients have to think about how they're going to style their hair, how they're going to wash their hair. It impacts, intimacy, relationships, when it comes to the genital area. So again, it was just looking at a different kind of, underrepresented population.
Yeah.
And I think it's interesting. I brought this up in a talk recently, all of these biologics are actually approved for moderate to severe psoriasis, right?
That's true.
And moderate psoriasis is defined by the National Psoriasis Foundation as 3 to 10% body surface area. But all of the insurance companies always want to hear that 10% magic number, right? That's what they're looking for to get these prior
and that's what we
authorizations.
think they want
And
too.
so exactly. And I think it's all been put into our heads so many times that now when a patient walks in the door without 10%, we think they don't need a biologic.
Yes.
But that's not how we should be practicing. We shouldn't be dictated by what the insurance companies are asking of us.
Really
because
good way to think
technically,
about
anybody with 3% and up has moderate psoriasis, and they should be a candidate for biologic therapy. Again, this gets back to how the clinical trials were designed back in the day. Those patients always had greater than 10% body surface area. So again, that's what the insurance companies have latched onto, and now that's what we're all doing.
Yes.
But it's not the right way to treat our psoriasis patients.
Yeah, that's actually it's like when you think about it that way, it's kind of like operant conditioning. Like we've been conditioned, well, we're not going to get this approved, so it's not the right thing for this patient, which we know from our trials that that's not true. Like if they have, especially a special site, so like taking a sexual history, genital area, like these are, and patients don't volunteer this information.
No,
I think that's
not
the thing.
proactively.
And definitely not in a 10 to 15 minute consultation.
Yeah,
They're not
or like
gonna
their
go,
first 1 or 2 visits with
they're
you,
not gonna
right?
go
They don't feel
that in depth
comfortable
with their very, like private kind of information that way. So like we almost need to be thinking of it for them.
Yeah.
Rather like that has to be uncomfortable. Like
Exactly.
there's no way that if you have that much involvement in the genitals or the scalp that it's not bothering you.
Totally.
I mean, there's the rare patient that really, they have like the scalp involved. They're like, it's not itchy, it's fine. But the most majority of patients I see with scalp psoriasis, for example, they're happy to have it gone.
Yeah,
when it's improved.
Totally.
So.
Yeah. And then with the spectrum study, we saw similar results. The patients all did really well as expected. So the moderate patients, did just as well as the more severe patients did in the pivotal trials. And across all those special sites as well, the efficacy of the drug really held out. And again, I don't think the point of the study was to, prove that it worked well in any sites because we knew that. But I think now this study provides us with ammo. So when an insurance company comes back to us and says like, oh, well, they only have 5% body surface area, they don't really need a biologic, we can actually pull out this study and actually submit it with our appeal and say like, actually, this study does show that this drug can work in this population and these patients need this medication. So, So again, hats off to J&J for kind of thinking about these things that other companies are not thinking about.
It's very innovative because a lot of people are just going to do the same thing, same clinical trials, same way, and it's not changing the way we think, and it's not serving these patient populations. So it's really true. I mean, it's so arbitrary. Even our 3% versus 2% versus 10 or 11. We kind of put these just guidelines, but I can imagine as someone that has never had skin disease comes to your clinic, you now diagnose them with maybe scalp or genital psoriasis, and they go, okay, well, what's the pill I can take to make it go away? No, you can't.
You can't. Yeah.
This is, you're going to have this for a really long time, and then you don't give them adequate enough suppression or therapy for it.
Yeah.
I mean, that's really ultimately what's happening when we're kind of just arbitrarily putting people in these camps.
Exactly. And the International Psoriasis Council has kind of recategorized how they look at psoriasis severity. I mean, they're saying we shouldn't even be calculating body surface area anymore. Like we shouldn't be looking at that. They say patients are either candidates for topical therapy or they're candidates for systemic therapy.
Yeah.
We're not looking at body surface area. And how do you become a candidate for systemic therapy? You either have generalized disease, more than 10% body surface area.
The very kind of obvious patient you can think of.
Yeah. Or you have psoriasis in special sites, again, the ones that we just talked about. Or or you've tried and failed topicals. So even if you have like 2%, but you've tried, 5 different topicals and your psoriasis is not getting better, I think it's time to talk about a systemic drug. And our drugs have gotten so safe at this point that it's okay to treat someone with 2 to 3% body surface area with these medications, because the risk-benefit ratios are so beneficial. They're in the right direction, right?
Yeah,
for these patients.
It's such a good point. Our innovations have gone faster than like our minds can keep up with, because we're still like, well, like I wouldn't put somebody with a little bit of scalp psoriasis on cyclosporin.
Right.
But that's not what we're talking about anymore.
Exactly.
I mean, like
but you would put them on Tremfya,
but
right?
we would absolutely put them on Tremfya.
Yeah,
like, it's
totally.
going to be like super safe. So yeah, it's kind of crazy how we categorize these, and when we put systemics all in the same category too, which is also not correct. Like just because something is going inside the body does not, those two things
they're not equivalent.
Those are not equivalent.
Yeah,
so
exactly.
We do have these just like arbitrary categories, which is why it's important. Like we mentioned with these studies, you could look at the onset and say, oh, well, of course Tremfya worked for all these people because it's a highly effective medication, but that's not the point. The point is to actually like change how we look at the disease, like how we look at the populations, and just these and just starting the conversations.
Exactly.
Which is like really amazing. So, but thank you so much for kind of going over it. I know the nuanced things, which I think why the podcast format was really great to talk about it.
Exactly. Because again, if you look at these studies, you're going to say like, well, I don't know why they did
another study.
Yeah,
I'm like, oh, like surprised that psoriasis and Tremfya works. Like obviously.
But the context is important.
The context is so important. And then when you really think through it, you're like, whoa, it just gives you things to kind of think about. And the therapeutics, it's like chicken and egg. The therapeutics change how we think about things, and how we think about things, hopefully changes the therapeutics. So, I mean, hopefully these are all good things for our psoriasis patients. I mean, there's still no cure, right? Is there something you would know? Is there something on the horizon?
Not yet. But
Okay,
I think
has Dr.
maybe
Liao solved it yet?
Exactly. Maybe in our lifetime. I don't know. We'll see.
Yeah, but I mean, the therapies now are so good that it's almost like it's not all or none. I mean, you can live disease free with these like really safe medications.
Totally.
We shouldn't only reserve them for certain subsets of people that fit a certain skin color and an artificial body surface area. Don't gatekeep. If there's a patient sitting in front of you and their life is altered by their skin disease, which is very understandable if you think about it. Like you go on a trip and you get a bug bite, and it's it's annoying.
Yeah, totally. So can you imagine what they're going
through? That's less than 1%. Let's put it that way.
Exactly.
So when you just are empathetic on that level, it's really amazing. So, well, thank you so much.
Thank you.
As always, we've learned so much.
I'll be back.
Opened up our minds. Please be back all the time. So, thank you again.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.